Hello everyone. My PhD topic is about the evaluation of new preoperative interventions in order to enhance recovery after major abdominal surgery. Okay. My name is Anna Sebestyén and I work at Heimpál Children's Hospital. You can see the names of my supervisors who are helping me with my projects. I believe there are some old principles and paradigms in perioperative patient care that are kind of old school now. We need change, we need a new approach. So my mission is to provide high quality of evidence to support this changing process. I have two ongoing projects at the moment. The first one is about the effects of preoperative carbohydrate loading on postoperative outcomes in patients undergoing elective major non-cardiac surgery. This is a systematic review and a meta-analysis. So my target journal is the Annals of Surgery, and we are very close to finish the manuscript. So about the background. Traditionally, it is forbidden for patients to consume any kind of fluid or fluid prior surgery after midnight. And this is called preoperative fasting, which is technically a stress situation. And when this stress adds up with the surgical stress and the surgical trauma, these together can contribute to an increased rate of postoperative complications. Despite all these facts, preoperative fasting is still a worldwide routine. However, the most recent enhanced recovery after surgery guidelines strongly recommend the preoperative carbohydrate loading instead of conventional fasting, but the quality of evidence is still low or moderate. So in this study, we would like to investigate the effects of preoperative carbohydrate loading compared to preoperative fasting. Oops. A clinical question is the following. Does preoperative oral carbohydrate loading decrease the rate of postoperative complications compared to preoperative fasting? And our patient population is adult patients who are undergoing elective major non-cardiac surgery under general anesthesia. And the intervention group, we received the preoperative carbohydrate loading as an intervention, and the comparison group, we received placebo or they will fast. And our primary outcome is the length of hospital stay, but we have some secondary outcomes as well. Okay, you can see the number of results we found during our search in each database, and you can see our search key as well. And after the selection, we have 55 eligible full texts for the meta-analysis and the systematic review part. Here's the first outcome, which is the length of hospital stay. We compared the length of hospital stay with, we compared carbohydrate loading with fasting, and we compared carbohydrate loading with placebo. So this is the first result, and as you can see, the length of hospital stay is almost 2 days shorter in the intervention group than the fasting group. So this is a clinically and statistically significant result. But we didn't find the same results when we compared the carbohydrate group with the placebo group. Here is the CRP levels, which are not statistically significant results, but this can be a promising direction to investigate further inflammatory levels after surgeries. And we have some secondary outcomes, which are the postoperative glucose and insulin levels. We found no statistically or clinically significant results, so we will include them in the supplementary table and not in the main manuscript. So, in summary, we have a big number of eligible RCTs, but there are a few limitations, such as heterogeneous patient population, because major non-cardiac surgery is a very wide term, and there are different ways of administrations of the intervention and different durations of fasting. So in the future, we would like to recommend the further studies to be performed with more homogeneous populations. My second project is called Multimodal Individualized Goal-Directed Fluid Therapy, MyGDFT for short, in patients undergoing pancreatic surgery. This is a protocol of a randomized trial. So, inadequate hemodynamic management during any kind of major surgery, but especially in pancreatic surgery, can result in either tissue hyperperfusion or fluid overload, and both are associated with worse postoperative outcomes. And there's an already existing and well-working strategy called goal-directed fluid therapy, or GDFT, and we would like to personalize it a little more and complement with some new thoughts, and we think we can help personalizing the management and improve the outcomes. And this would be the first study that would compare the effects of MyGDFT and the conventional fluid therapy. So this is the clinical question: does MyGDFT reduce the postoperative complications compared to conventional fluid therapy in patients undergoing elective pancreatic surgery? So the patient population include adult patients. The intervention group will receive the MyGDFT guided management. The control group will receive conventional fluid therapy. And about outcomes, I will tell you a little more a little later. And we hypothesize that MyGDFT is superior to conventional fluid therapy because we think it can reduce the postoperative complication rate and fastens the hospital discharge. So we would like to include adult patients from both sexes undergoing pancreatic surgery and only ASA 1, 2, and 3 patients. We would like to exclude ASA 4 patients, pregnant or lactating women, and patients with inoperable pancreatic cancer. You can see you can see the MyGDFT guided management and what parameters we would like to monitor. And you can see the conventional management and the main differences between the two managements highlighted with red. And also the device we will need for the MyGDFT guided management. This is called PulseoFlex monitor. And here are developed algorithms which are it's a little time-consuming at the moment to explain in details, but I wanted to show you what we managed to develop. And here are the outcomes. Our primary outcome is the overall complication rate defined by Salzwedel. And these include the infections, the respiratory complications, cardiovascular, abdominal, renal, and other complications. And we have some secondary outcomes as well, such as length of hospital stay, and so on and so on. So here is an overview about my 2 ongoing projects, and I would like to thank you for your attention.
I have a question regarding to your second project about fluid therapy. What kind of fluid do you use? Is it the same in both arms?
Yes. Actually, the fluid bolus is the same. For example, you can see that that's the conventional fluid bolus, but we will use, for example, vasopressors or
do you use lactated ringer or saline, or?
Sorry?
Do you use lactated ringer for fluid therapy, or isolite, or what kind of fluid do you use?
It depends on the department.
And do you think that it could be compared if they use different types of fluids?
Sorry, again?
Do you think that it could be compared, that they use different kind of fluids?
It can be. We have to define what kind of fluid we would recommend. We didn't discuss this part at the moment since we started to develop this project. It's under discussion.
My question regards to your meta-analysis project and to the population of that. You mentioned that the population was the patient with non-cardiac surgery.
Yeah.
It's a very wide population. And could you, or how could you decrease this effect on the results? Or is it possible somehow to decrease the effect of this heterogeneity on the results?
I'm not sure we can decrease it. There's like a tendency that colorectal surgeries tend to prefer carbohydrate loading than any other kind of surgeries, because we have included a lot, like craniotomies, lung surgeries, maxillofacial surgeries, and so on. But that's the pattern I noticed, that colorectal ones tend to prefer this intervention. But statistically, we couldn't do that subgroup analysis to prove it. It's just my theory and my note on it.
About your RCT, why just pancreatic surgery? Because we know in the literature it exists that GDFT is potentially quite useful for every kind of abdominal surgery. So why did you want to focus specifically on the pancreatic surgery and not all the other types of surgeries as well?
It's because pancreas is the most sensitive organ for the fluid imbalance, and we would like to just go for the bigger target, not to the other ones. And also we have this pancreatic centrum, which is very useful to have if you want to do like this kind of
yeah, but it's already planned as a multi-center trial. So it doesn't matter if we have a pancreatic center here or not, because we will then need another pancreatic center anyway, no?
I think this is my answer. Like, this is the most sensitive organ, and I think this is why we can monitor the slight changes and slight reactions to the administered interventions, such as fluid bolus, vasopressors, and so on and so on.